Good afternoon, everyone. My name is Molly Alawade, and I'm the Director of Education here at the American Kidney Fund. In honor of Fabry Disease Awareness Month, I'd like to thank you for joining us for today's webinar, The Link Between Fabry Disease and Your Kidneys. Before I turn the presentation over to today's speaker, I'd like to direct your attention to the control panel you should see on your screens. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the Q&A box. We'll see your questions and we'll do our best to answer them by replying to you in the Q&A box or reading your question out loud during the last several minutes of the webinar. For those of you in attendance who are health professionals, we are glad that you've joined us today and hope you'll recommend this webinar to the patients you work with. However, as a friendly reminder, this webinar is not accredited for continuing education credits. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. Without further ado, allow me to introduce today's speaker, Dr. Michael Maurer. Dr. Maurer is a pediatric nephrologist at the University of Minnesota. He has more than 15 years of research experience in Fabry-related kidney disease. His early clinical interests were in the management of acute and chronic kidney failure, helping to adapt hemodialysis and kidney transplantation to infants and small children. His more basic research efforts initially focused primarily on diabetic kidney disease, the cause of nearly half of chronic kidney failure in the Western world. Over the years, Dr. Maurer has published more than 350 research articles and 90 book chapters on his areas of expertise. Notably, his lab has trained more than 20 young investigators, many of whom remain actively involved in research. Thank you, Dr. Maurer, for joining us. I'll now turn the presentation over to you.
Thank you, Molly, and I thank the American Kidney Fund for inviting me and giving me this opportunity to speak with you about Fabry kidney disease. My objectives today are to explain to you the signs and symptoms of Fabry kidney disease, how Fabry causes kidney disease, the treatment of Fabry disease, and how Fabry disease affects families. And here are my disclosures. Now, Fabry disease is an inherited disease, which means that it runs in families. It's caused by an altered gene on the X chromosome, the GLA gene, and that gene provides instructions to the cell for making the enzyme alpha-galactosidase. More than 1,000 different alterations of this gene have been described that can cause Fabry disease. And the more severe the alterations, leads to a more severe disease, the so-called classic form of Fabry disease. Less severe alterations lead to milder cases, and they're called late onset disease. Now, Fabry is a heterogeneous disease, which means it affects different people differently. And as I'll show you, that can occur even within families. Males have only one X chromosome, and females have two. And very early in fetal development, for every cell of the female, one X is silenced. Otherwise, the cell would be confused getting signals from the two X's. So one is working and one is not. So in females, approximately half of the cells are Fabry cells and half are normal, while in males, all cells are abnormal. Males with classic Fabry disease have a very high risk of injury to vital organs. Now, as I suggested, there's no perfect relationship between gene abnormality, and the severity within a given family. So here is a family in which the males that are affected by Fabry disease are the black squares. And this individual has minimal kidney findings at age 61, and Fabry is expressed in this person clinically mainly as cardiac disease. And here's another person in the family with the exact same gene defect, but this person required a kidney transplant by age 40. And this young male at age 23 is too young for us to predict what the kidney outcome will be. So obviously, if different people in the same family with the identical gene defect can have different clinical courses, it suggests that there are modifiers of the disease which either accelerate or protect from the injury that Fabry disease causes. Now, this disease affects multiple organs, and the ones we worry about the most are the brain, the heart, and the kidneys. In terms of the signs and symptoms of Fabry disease, the skin rash is characteristic. Consists of dark red or purple raised dots that don't blanch. That is, when you put pressure on them, take your finger off quickly, they're still dark red. They don't fade with pressure. As you can see over on the right side, the rash appears primarily on the buttocks, the groin area, often just around the umbilicus and in the upper thighs. It's not there in young children, begins usually in adolescence. It's present in virtually all classic males and about 30% of classic females. And it may not be there at all in milder cases. But when the rash is seen, it is diagnostic of Fabry disease. The eye changes are also characteristic. As you can see in the picture on the right, there is a whorled or spoke-like pattern in the cornea, and this is called cornea verticillata. It's present in almost all classic males and 70% of classic females. It's there fairly early in life, and so it can be seen in children 6, 7, 8 years of age. Doesn't impair vision, but it's helpful because it is diagnostic of Fabry disease. The neurologic complications are important. I would have first look at the left side of this slide. Acroparesthesias occur mainly in the hands and feet. And this is pain and burning, which can be severe. It's due to nerve damage, begins in childhood, often before age 5 or 6. And there can be pain crises that are induced by exercise or fever or hot weather. And you can imagine a child not able to run and play with their friends because that can induce a pain crisis and how that affects their relationships with their peers. Deafness is quite common in Fabry disease. It can affect one or both ears. Onset could be sudden or gradual. And some patients also have tinnitus or ringing in the ears and vertigo, dizziness where the room seems to be spinning. Now on the right side, you see that many patients have decreased sweating, some no sweating at all. And this produces heat intolerance, which can induce fevers and lead to the pain crisis I described. And this is due to injury to small vessels and nerves. And about 40% of Fabry patients will also have decreased tears and saliva. The big issue for neurologic complications is stroke due to clotting of small arteries in the brain. And when the artery is not completely blocked, it can diminish oxygen going to the brain and produce transient ischemic attacks where there's, for example, weakness of your arm that goes away in 10 or 15 minutes. Strokes can lead to permanent brain damage and can be quite debilitating. Gastrointestinal complications are important. Some patients have abdominal pain after every meal, and that inhibits eating. Diarrhea is common. Imagine what it's like if every time you go to the grocery store, you have to worry about whether you can make it there or back without a diarrheal episode. Some patients have diarrhea alternating with constipation or just severe constipation. And nausea is common. So the gastrointestinal complications often have a major negative impact on the quality of life. The cardiac complications are extremely important. They manifest as enlargement of the left side of the heart in males, the left ventricle, also known as left ventricle hypertrophy or LVH. And there also can be scarring of the heart called myocardial fibrosis. Usually begins in classic males around the age of 30 or older, can lead to heart failure and death. And females may have scarring on MRI without heart enlargement. So whereas ultrasound in males can delineate early cardiac disease, that may be missed in females, and they are better studied by MRI. Fabry can lead to electrocardiographic abnormalities, problems with the heart rhythm that can lead to sudden death. And patients with Fabry not unusually will end up with implanted defibrillators or pacemakers. And Fabry patients may also have heart valve abnormalities. Cardiac complications are the leading cause of premature death in patients with Fabry disease. There's a cardiac variant of Fabry disease, for example, in Taiwan. It's the dominant form of the disease. These patients usually have some residual enzyme activity, presents later in life, sometimes with no other Fabry manifestations, and it tends to be under-recognized. So in one study, 230 men with enlarged left side of the heart were looked at, and 3% of them had Fabry disease. So it's important, and most cardiomyopathy clinics now screen for Fabry. The psychological issues are also important. Anxiety is common. Depression occurs in upwards of 40% of patients. And some people feel that depression may be not simply a reaction to a chronic illness, but may be, in fact, a primary manifestation of Fabry disease. And it's very important to assess patients for depression because you want to prevent the fatal outcome of depression, which is suicide. You want to be sure to detect this and treat it appropriately. Now, how is the disease diagnosed? Often there's a family history, so it's pretty straightforward. But in about 5% of families, this is a new mutation which hasn't been there in previous generations. So you can't rule it out by the absence of a family history. In the classic males, by definition, the enzyme activity level is less than 5% of normal, usually less than 1%. And it can be diagnosed also by DNA analysis. In females, however, enzyme activities may be low or maybe in the low normal range, and so they may need a DNA analysis. And then if there are this typical skin and eye findings, you can then confirm the diagnosis with either a DNA or enzyme levels measurement. There's now a new substance that could be measured in the blood or urine, and that can be helpful in diagnosis, especially in females. Timing of diagnosis is really important. On average, if there's a family history, the age is about, on average, 16 years. But in the absence of a family history, it's 28 years. And that 12-year gap is important. The disease is often diagnosed by skin doctors based on the rash, eye doctors based on the eye findings, neurologists on the nerve pain, nephrologists, usually on a kidney biopsy as an unexpected finding sometimes by screening patients with end-stage kidney disease, dialysis transplant recipients. The point is, the disease is rarely made by pediatricians and internists. Rob Hopkin is a pediatric geneticist in Cincinnati, and he had a patient who was 14 years of age who wasn't playing much with other kids, was kind of shy, and his parents thought he was depressed. So they referred him to a psychiatrist, and the patient had done some reading on the internet. And the psychiatrist said, "You take these pills for depression." And the lad said to the psychiatrist, "I tell you what, doc, you test me for Fabry disease, and if I don't have it, I'll take your pills." And that's how his diagnosis was made. I saw a patient in a clinic who was 52 years of age, protein in his urine, decreased filtering function of the kidney, and his diagnosis was made at the Mayo Clinic when he had a kidney biopsy and the unexpected finding of Fabry disease. And I told him the story of this young man. And when I looked up, he and his wife were crying because that was his story. He had all the complaints over years of Fabry disease. Nobody believed him. Nobody checked. Nobody read. And he ended up with kidney failure that could have been avoided by early treatment. So the diagnosis is often late. And what's shown here on the left side is the onset of symptoms, which can be in the first 10 years of age, and the delay in diagnosis. And on the right side, with when the delay on average is in the late 20s, already 25% of patients have high levels of protein in their urine. And I'll explain the significance of that shortly. And by the age of 35, when they're first diagnosed, it's 50% that already have proteinuria. So the earlier you find out about Fabry disease, the sooner you can track your treatments, learn how to manage the condition, and start appropriate therapy. Now, how does Fabry disease affect the kidneys? Alpha-Gal is an enzyme your body makes. It breaks down a substance called GL3, a fatty substance in your cells. And if you don't have enough enzyme, GL3 accumulates in cells, it builds up in the kidneys, and ultimately causes damage. The very first finding clinically of Fabry renal disease is an increase in protein in the urine. That could be total protein. All the proteins in the urine are albumin, which is the most abundant of the proteins circulating in your blood. And proteinuria can have its onset as early as age 14, but usually it's in the late 30s and 40s. Chronic kidney disease, where people have already lost about 40% of kidney function, on average, shows up at age 42 in untreated males. And within about 10 years of the onset of proteinuria and about 4 years on average from the onset of CKD with filtering functions 60% or less of normal, end-stage renal disease develops in most classic males without treatment. It can occur as early as 21 years of age, but the peak incidence of end-stage disease is in the 50s. More recently, registry data has found that males and females can have preserved kidney function well into their 60s. And some of these may represent the late onset patients. Excuse me. Now, in this study by Professor Rafe Schiffman, he looked at predictors of renal events, those being dialysis, transplant, or a 50% decrease in filtering function. And what you could see is that at baseline, if your urine protein creatinine ratio was 2, that's sort of a moderate amount of protein in the urine. Already, it predicted 70% of the patients would progress to one of these renal events. And by the time the protein creatinine ratio is 3, it's virtually 100%. And now you can see why, when the diagnosis is made late, it may be late to prevent kidney disease from progression. Now, in this study, the rate at which the filtering function was lost was looked at in males and females, and they were divided into quartiles. The first quartile had the 25% with the slowest rate of loss, the fourth quartile with the fastest. Now, if you look at the males, in the third quartile, they were losing about 3.3% of filtering function per year, and they had a moderate amount of proteinuria. In the females, in that third quartile, was only 0.7% per year, with about the same range of proteinuria. In the fourth quartile, the men were losing 5.6% per year. This is very fast for deterioration of kidney function, and then higher levels of proteinuria. And females in the fourth quartile were only losing 1.3% a year, and with similar levels of proteinuria. So there's a key message here. Urine protein levels in males and females can have vastly different meaning. And it's very important when doctors talk to patients about what their risks are, that they understand this difference. Now I'm going to talk to you a little bit about basic kidney structure. The basic element or structure in the kidney is the nephron. And there are about 1 million of these in each of your kidneys. And the nephron consists of the glomerulus, which is the filter apparatus, and the tubular system, which drains urine or filtrate from the glomerulus. Now, in terms of fluid that's filtered by the kidney, every 10 to 12 hours, your entire body weight goes through this system. Now, you can imagine that that doesn't all end up in the toilet, or you would quickly dehydrate. So the vast majority of fluid which is filtered is reabsorbed through this tubular system and the capillaries that surround the tubules. Now I'm showing you here a cross-section of glomerulus in more detail. And the afferent arteriole brings blood to the filter, and the efferent arteriole takes the blood away after it's been through the filter system. Now you might ask why an artery is taking blood away from the glomerulus, where in other tissues in the body, it's always a vein. And that's because the pressure in these tiny capillaries is about 25 times higher than it is in your fingertips. So your glomerulus is an espresso machine. It's not a drip coffee filter. And that's how that huge amount of fluid gets forced through that system. And that is the filtering. When I'm referring to glomerular filtration rate, that is the rate at which the blood is filtered by the kidney. Now I'm going to show you a couple of these capillaries in more detail. So the capillary is the open space, and it's surrounded by an endothelial cell. Then there's a basement membrane outside of the capillaries, which is part of the filter wall. And in between the capillaries is a structure called the mesangium, which forms the architectural framework for the glomerulus. And outside is the podocyte that I'll talk to you about more in detail. And this is a cartoon of just a section of the filter wall. And here you see where the blood is circulating, the endothelial cell, which actually has holes in it and lets fluid pass very readily. Then the glomerular basement membrane and the podocytes with its foot processes, and in between them you see a little dark line, and that's a filtration slit where most of the filtration goes through. Now this is a bird's eye view. This is a scanning electron microscope of the outside of podocytes. They're different colors just to show you that the foot processes of one podocyte are interdigitating with its neighbor of a different color, and the dark line between them is the slit through which the filtration occurs. And the podocyte is very important in keeping protein and other large molecules out of the urine. Now, on the right side, on the left side here is a normal capillary of a glomerulus, and on the right side, Fabry. And you can see with these inclusions of GL3 in podocytes, why these inclusions have been called zebra bodies. Now you see them there in the podocytes, in mesangial cells, and rather in endothelial cells and in mesangial cells. And here you're seeing relatively normal foot processes, and with the red arrows, the foot processes that are markedly altered and widened. And this widening is associated with protein in the urine. So we looked at children ages 4 to 19. There were 14, 8 boys and 6 girls. In our studies, we found that the inclusions in podocytes increased with increasing age, but not in the other cells, not in endothelial or mesangial cells. Remember, this disease progresses with age. So if it's not progressive in a cell, the cell may be less important in the manifestations of the disease. And these inclusions in podocytes correlated, their amount correlated with proteinuria, but not the inclusions in other cells. They also correlated with foot process width. Now there's progressive podocyte loss with age. Podocytes replicate poorly, so when they're lost, they're not easily replaced. We looked at 35 males with classic Fabry disease from childhood, age 4 up to 60. And we found a progressive decrease in podocyte numbers in glomeruli with increasing age. And we know that podocyte loss is associated with scarring of glomeruli, proteinuria, and loss of filtering function. Now, this is a female, and the red stars are over the cells that are the Fabry cells, the abnormal cells, and the blue stars are over the normal cells. And you can see in the upper left rectangle a cluster of these Fabry cells, and on the lower right rectangle, you can see that these are the normal cells. And that's how they appear. That's what we call mosaicism of the clustering of normal versus abnormal cells in the female patients. Now, we studied females and found that about a little more than half of the podocytes had no inclusions, and all podocytes in males had inclusions. And in the podocytes with inclusions in the females, the amount of inclusions per cell was virtually identical to what we saw in males. And this is consistent with an all or nothing phenomenon. The cell is either sick or healthy. It also suggests that having a normal neighbor doesn't help you very much if you're the Fabry cell in that system. And worrisome is that in females, the percent of Fabry podocytes decreases with age. And that suggests that these Fabry podocytes have a survival disadvantage. So in women above age 40 and 50, you may find very few Fabry podocytes, likely because the Fabry ones have died and dropped off into the urine. Now I'll talk a little bit about treatment with Fabry disease. Now the primary treatment in the US at this time is still enzyme replacement therapy. Now how this is accomplished is that viruses have the gene for this enzyme included in the viral DNA. And then the virus is given to cells in culture. It goes into those cells. It kidnaps the DNA production for the enzyme. And now these cells make the enzyme. The the enzyme is purified from the cell culture, and it's given by infusion into patients intravenously, usually every 2 weeks. And we studied kidney biopsies of patients before and about a year after enzyme replacement therapy in 6 adult male patients. And what you can see from the graph on the right is that the inclusions per podocyte decreased from baseline in virtually all the patients. But the amount of reduction was greatest in the biopsies that had the most at baseline. And the reduction in inclusions in podocytes correlated with a reduction in podocyte size. So as the inclusions disappear, the size of the podocyte decreases. And this was also associated with a reduction in foot process width. Now there's a new player in the treatment arena, and it's a drug called migalastat. Now, when this protein molecule containing the enzyme is made, normally it traffics to a part of the cell called a lysosome. It's a particle within the cell that has a lot to do with digestion of substances within the cell that need to be broken down. And the lysosome has an more acid pH than the rest of the cell. And the enzyme involved in the agal enzyme works best in an acid environment. So the enzyme has to traffic to the lysosome. And hanging around in the rest of the cell doesn't do the cell much good. And there are elements on that molecule that guide it to the lysosome. And when the defect genetically is in those guidance aspects of the molecule, then this drug, migalastat, which is called a chaperone, helps guide the molecule with an active enzyme portion, but otherwise would get lost to the lysosome where it can do its work. And this drug can be given orally, and not every patient with Fabry disease has that kind of defect. So about 40% of patients have what's called an amenable defect where migalastat can work. And we studied patients that received migalastat at baseline and 6 months. And what you can see on the right side is that the amount of GL3 per podocyte diminished in 6 of the 7 within just 6 months and was stable in 1. And as with enzyme, as the inclusions decreased, so did the size of the cell. And this was also correlated with a decrease in, decrease in the average foot process with an indicator of less injury to the podocyte. Now, age of institution of treatment can be important. And these images were shared with us with our colleagues in Norway that are also studying children with Fabry disease. And here you can see at baseline, these podocytes filled with inclusions in a patient at age 7 years. This male was treated for 5 years, and at the end of that 5 years, there was no GL3 to be seen in podocytes. And we have a couple of patients like this as well. The point I'm making here is that complete podocyte clearance has only been seen in young children. And there's another argument for not waiting until there's advanced damage, but starting treatment before that comes. Now, there are some new treatments that are coming around. One is substrate reduction therapy. And how this works is that inhibits the enzyme that makes the GL3 that accumulates in cells. So if you make less of it, then you're going to have less accumulate. And this is an ongoing clinical research area. The other new research area is gene therapy. Remember how I told you that you make a virus express the DNA and you put it in cells and the cells make the DNA. What gene therapy is, you have a virus that doesn't hurt cells, that is transformed to with the DNA for the gene. Now you're not giving it to cells, you're giving it to the patient. The virus goes into their cells and those cells make the enzyme, which then go into the blood. And gene therapy is being developed by a number of companies. It's fairly early on in its development, but it holds the possibility that we might eventually have a cure for Fabry disease. Now, Fabry treatment takes a team. Usually the leader of the team is a geneticist with an interest in this disease, but included in the team may be a cardiologist, a heart doctor, neurologist, a kidney doctor, a gastroenterologist, an audiologist dealing with the ear problems, and then psychologist or psychiatrist or mental health counselor. And it's important that centers that treat Fabry patients have this group of experts available to involve themselves in the care of Fabry patients. Now, I'm going to end by talking about how Fabry disease affects families. And these slides were provided to me by Jack Johnson. And Jack is the director of the Fabry Support and Information Group. And sorry. And it's important that you take one piece of information from this slide, that you can reach that group by Googling fabry.org. And then you can connect with the Fabry Support and Information Group. There's a lot of information about Fabry disease there. There are links to Fabry groups within your community. There's lots of helpful information for family members. And there's even a Fabry summer camp for children. So this is a great resource. Remember fabry.org, and you can get to this website, which you'll find extremely useful. Now, you know Fabry disease runs in families. And one person is diagnosed, an average of 5 other family members will be found. And those includes brothers and sisters, children's parents, aunts, uncles, and cousins may be affected. And so when one patient is diagnosed, a lot of people can benefit. So if you or someone in your family is diagnosed with Fabry disease, it's important for the other family members to talk to their doctors about being tested. Now, it's important to understand who's at risk and how Fabry disease is passed on. And one way to do that is to outline a family tree. So if you have, for example, a father with Fabry disease, and he has a son, his son cannot have Fabry disease because the father's problem is on his X chromosome, and the chromosome he passes on to his son is only the Y chromosome. So these pedigrees help to understand who may be at risk within a family and who not. It's also important for people to understand that this is genetics, and it is not a choice. We don't get to select the genes we're born with. There's no fault, there's no guilt, there's no blame. And this is an important aspect of genetic disease that we want people with this disease to understand. Now, everybody responds differently. There are some people that are very proactive in seeking help for themselves and family members. And these are the ones that we doctors who see Fabry patients have regular contact with. But then there are the people who don't want to know, who are in denial. And these are the ones that need to be referred to doctors, and often they need family members to help them to overcome denial and reach out for the help that they need. And in dealing with patients with denial, we need to understand that guilt may be paralyzing and a block to acceptance. And it's important to be patient, take time in letting people come around to what they need to do. Important to point out the positive aspects of care and treatment, and perhaps the prevention of vital organ disease. And you, in talking to people, you may want to discuss your concerns about the complications that may occur with lack of action for oneself or for other family members. And pointing out personal experiences to others may be very helpful to them. Now, some tips for Fabry patients and caregivers. As I've suggested, build a strong support network and use fabry.org, get to that site. And that's one way to begin building such a network. Find people to talk to, share experiences with them and learn from them. And this breaks down the feelings of isolation and loneliness that can happen with chronic disease, one especially that can limit certain kinds of activities and where people do not understand the symptoms you may have that are hard to explain. Make sure to take care of yourself. This is something I say often to mothers who have Fabry disease, who pour their care into their children and neglect themselves. And also consider that there are common stressors that lead to mental health issues. Important to consider talking to a mental health professional. So that is the end of my talk. I thank you very much for your attention, and we do have time now for questions and answers.
All right. Well, Dr. Maurer, thank you so much for that insightful discussion. We've got a couple questions that came in prior to the webinar through registration, so we'll go through them now. So our first question, and this really speaks to more so what you were just talking about, which is where can Fabry patients go to find support groups?
So the doctors in your community, the geneticists often that see a lot of Fabry patients, they will have some information for you about local groups. We have a Fabry group here in Minneapolis. We have meetings with patients with storage diseases, including Fabry disease, once or twice a year. People can bring their children. There are children's activities. There's educational sessions, and there are breakout sessions where people can get to know each other. And then I refer you again to the Fabry Support Educational Foundation led by Jack Johnson. And you need to remember only fabry.org. And that's a very valuable source of information, direction to support groups in your community, and activities locally and nationally.
Wonderful. Those are all great tips. So someone else sent in this question. A few people in my extended family have kidney failure, but I don't know if they had Fabry disease. How do we know if Fabry disease runs in our family?
So if there's somebody who's been diagnosed with Fabry disease, then it's pretty straightforward. It runs in your family. If nobody's been diagnosed and you think that you may have symptoms of Fabry disease, then you would need to be tested. And the number of tests can be done. Test in males with the classic disease would be measuring the enzyme activity. The most definitive test is looking at DNA for looking at abnormalities for the gene that can be affected in Fabry disease. And once there's an individual diagnosed with Fabry disease in the family, then a pedigree can be set up, and there can be the people would be delineated that are potential risk. I gave the example of a father who has a son. That son cannot have Fabry disease from that father because he gets the Y chromosome from the dad, and the Y chromosome is not involved. This is a gene on the X chromosome. But if there's a daughter, then the daughter would be at high risk of Fabry disease because one of the two X chromosomes that the daughter has to come from the father. So the daughter will necessarily have an abnormal Fabry gene and have the disorder. So by looking at a family tree or pedigree, you can tell who's at risk. And you wouldn't want to waste time and money testing the son of the father with Fabry disease, but you sure want to test the daughter. So once the family tree gets outlined, then you can pretty well figure out who needs to be tested.
That's good to know. So someone else asked, speaking of testing, what kind of test should I ask for if I want to know if I have Fabry disease?
So some of it may not require a test. It may just be a physical examination. If you have the rash of Fabry disease or you have the classic eye findings, that's pretty diagnostic. You have Fabry disease, and the DNA testing is confirmatory, and the DNA testing will also tell you if you have a defect which is amenable to the new oral treatment, the migalastat drug, or whether you might require enzyme replacement therapy. So DNA is definitive. Enzyme levels are definitive in males if they are low enough. And in females, the levels may actually be low normal and require the DNA testing. So it's mainly clinical examination and blood testing. As I suggested, sometimes in people with males with protein in their urine and decreased filtering function, a kidney biopsy is done to try and figure out what kind of kidney disease the person has, and Fabry shows up on the biopsy, and the diagnosis is made that way. There isn't a new thing that's expanding in the US and around the world, and that's newborn screening. And more Fabry is included in newborn screens, and that's how some families are detected. This has gotten a little bit complicated because in newborn screening, there are a lot of gene defects that are showing up, and some of them are pretty minor defects in terms of disturbance of the gene molecule structure, and they may not have much significance. But as the years go by and Fabry screening becomes more widespread in terms of newborn screening, then this will become a more important way that this disease is diagnosed early on.
All right, great explanation. I know you touched a little bit on some of those early signs and symptoms. And someone else asked, are there any symptoms someone may have that are a sure sign that it is Fabry disease?
So in terms of symptoms, perhaps the most characteristic are the acroparesthesias. That is the burning pains in the hands and feet. And if someone describes severe pain with exercise or when they have a fever and it's in the hands and feet, That's how neurologists make the diagnosis, just by asking the questions to the patient about what is called neuropathic pain. And that is a very characteristic symptom. The findings of nausea, abdominal pain, diarrhea are not specific, but it's important to talk to patients about their age of onset and how long they've been persistent, and then to go from that to ask about the nerve pain, possibility of hearing loss, and some of the other symptoms. But a lot of the symptoms with Fabry disease overlap with other symptoms, and that's what makes it so difficult, unless you're thinking about Fabry disease, to include it in your differential diagnosis when a patient is presenting with these vague complaints. So I would say, in terms of symptoms, the most specific would be the pain in the hands and feet. In terms of signs or clinical findings, the rash and the eye findings are diagnostic.
Okay, that's good to know. So someone else asked, what can someone with Fabry disease do to protect their kidney transplant?
If they've had a kidney transplant. So someone who's had Fabry disease and then received a kidney transplant, I think that's the question.
Right. Mm-hmm.
So there's some good news here, and that is that the kidney that's transplanted, those cells have normal enzyme activity. So basically, Fabry disease does not reoccur in the kidney transplant. Now, with a minor exception, and that is that what happens in transplanted kidneys is that some of the cells lining blood vessels are actually cells of the recipient that go into the kidney transplant. And that's not a bad thing, because if your cells are lined by your own cells, those are not going to be recognized as foreign. They're not going to trigger rejection. So those cells may have some inclusions. But as I've suggested to you, inclusions in endothelial cells are not what makes kidneys sick in the long run. So the clear answer to the question, without this little factoid about endothelial cells in the renal allograft having some inclusions, is that Fabry disease does not recur in the transplant. However, we still need to worry in transplant recipients about the cardiac manifestations of Fabry disease, about the stroke risk, about some of the other organs that can be affected. So once you have your kidney transplant that's working well, it doesn't mean that all concern of Fabry disease is gone, because it won't come back in the transplant. But it is not a recurrent disease in the renal allograft.
That's a great explanation. It has actually caused people to ask a couple other questions concerning kidney disease and Fabry disease live today. So one question we just got is, I'm a kidney transplant patient, but never heard of this disease, even when I was on dialysis. Is this something I have to ask about?
So I think if you didn't have a definite diagnosis for your kidney problem, that you weren't told, oh, this is diabetic kidney disease, or this is some glomerulonephritis, some other kidney condition, cystic kidney disease, just unknown, chronic kidney failure, don't know why. Then for sure, you're going to want your doctors to look at your skin for the rash, to look in your eyes. And even if in the absence of those things, if you've had any of the symptoms, it wouldn't hurt to have be tested for Fabry disease. Remember, it may be too late for your kidneys, but if you're diagnosed with Fabry disease, that means there are people in your family that are undiagnosed, that can be diagnosed early, where kidney failure can be prevented. So I would bring it up. I would suggest to your doctor, I heard this talk on Fabry disease. We don't know why I have kidney failure. Could I have Fabry disease? Would you look at my skin? Would you have an eye doctor check my eyes? And if there's any concern at all on your part, doctor, why don't you go ahead and test me?
That's great advice. So we're almost at time, so I'm going to get us to our last question here. So we have a similar question, one from someone with lupus and one with someone with kidney failure, and they both asked, no one has ever mentioned Fabry disease to me. Is it possible that I was tested?
I would imagine that you would know if you were tested. But you could always ask, was I ever tested for Fabry disease? Most of the time when genetic tests are done, they're done with the permission of the patient. So we would ask for consent for looking at genetic questions. But it's easy enough to ask. And if you have kidney failure and nobody figured out why, there is a possibility, and there have been screening programs done in dialysis patients and in transplant patients, and about 1% of the time, people will have undiagnosed Fabry disease. But again, the key here is not just you, but other members of your family. So if there's doubt, it's worth bringing this up.
That's great. Well, thank you so much, Dr. Maurer, for this great discussion this afternoon. Thank you for taking the time to answer all of those questions. And this concludes today's webinar. This webinar was recorded and will be made available for viewing on our website, kidneyfund.org/webinars, within the next 1 to 2 weeks. You can also visit kidneyfund.org/webinars for updates on future American Kidney Fund webinars. When the webinar ends, please do not close your browser window. Your browser window should open a new tab to a webinar satisfaction survey. We ask that you please complete the survey. Your honest feedback will help us make our webinar program the best it can be. Thank you for joining, and we hope to see you again.